Yeah, if we'd like to go ahead and get started. Sorry, folks, I'm in the afternoon sun here and didn't think about moving my position. So I'm really washed out, but I'd like to say welcome. This is our next Chat with Chat, and we're really thrilled that you could be here with us today. As a favor, like you're hearing from all these Zoom meetings, if you would please mute your microphone during the talk to cut out the background noise, and we'll be able to use the chat function and see where the red arrow is there to address any questions or comments you might have. So I hope we'll have lots of questions generated from this presentation. I'd really like to start just with quickly reviewing what our mission is here. And I know you can read, but I'm going to read it for you anyway, because I think it's that powerful of a statement. To improve the health, healthcare, and quality of life for people with MS by connecting those affected by MS, caregivers, clinicians, and researchers, and to work together to accelerate innovation, research, and the application of new knowledge. And this is what we're doing today as an extension of this mission. I just fast forwarded too many. I'm with the Accelerated Cure Project's I Conquer MS project as a lead patient, but I'd like to give you just a brief background on ACP, as we call it. ACP was founded back in 2001 by a gentleman who had MS, but he was also a high-tech entrepreneur and had friends to help him fund the beginning of the Accelerated Cure Project. The key project at the time was the ACP repository, which is a biobank of samples that have been used around the world by researchers to look at trends, patterns, and causes of MS. The second major project that came up for the ACP was the opportunity to begin I Conquer MS. And I'll talk to that in a moment. And then the third project that I'm particularly proud of is the MS Minority Research Engagement Partnership Network. Now back to I Conquer MS and who we are. We're a patient-centered research network. We're patient-powered. The participants, everything that we do is governed by a majority of people who have multiple sclerosis. And we're able to put a unique perspective on everything we do by keeping the perspective of people with MS and the needs of people with MS at the forefront of everything we do. We have a number of projects currently we're working on via I Conquer MS. Some of them are internal to us and some are external. The first one you see, the My Research Surveys, is part of the access of data of Real MS. Real MS stands for Research Engagement About Life with MS, and this is our longitudinal study where we've been collecting data from participants for a number of years. The next one to the right there is our COVID and MS study, which we're very proud to be doing because this is the only patient-facing study that I know of COVID. What the impact of COVID is on our community, our knowledge of vaccines, and how we interact with COVID within the multiple sclerosis community. Down at the bottom, we see STEP for MS, which is supervised telehab exercise program for people with multiple sclerosis, which is being led through the Shepherd Center in Atlanta, but it's a multi-site center study that's looking at the difference of in-person and telerehab for exercise. And we're really excited to partner with them and provide the platform for them gathering their information. And then finally, you see Vote on a Research Question. This is our newest initiative. It's participant-driven research, and I'll talk to that in just a moment. The COVID research, you may know that we started this last year and it is still ongoing. So I would urge you, if you've not participated already, please log on, join, share your information. If you've been vaccinated, what your reactions were, if you've had COVID, there's a lot of different questions and a lot of ways that you can help build this body of knowledge so we understand better how COVID affects specifically the MS community. I mentioned participant-driven research. This is really exciting to me because the bottom line is, for years and years, I said, I've heard lots of MS research, but I've never had a research say to me, what do you want us to study, Laura? And fortunately now with participant-driven research, this is our opportunity to speak up and talk about what research we're interested in, to propose questions and have them voted on within the community. So I encourage you to go and look at our participant-driven research section on the website. And then finally, I mentioned this, the MS Minority Research Engagement Partnership Network. We all know that there's a lot of different voices that need to be heard in MS research, and minority inclusion is really critical to what we do and to better understand. So we're making a concentrated effort through this partnership network to be sure that we're reaching all people with MS. Here's a few examples of the type of research that we've done. We've done focus groups, we've done surveys, we collect endpoints, we do participant-driven research. The nice thing about iConquer MS is we're fluid, so we're able to do a variety of research in a variety of different ways that many researchers really have to envy, because we're nimble and able to react to what's going on quickly. I would encourage you, if you are not a member yet, please join us at iconquerms.org, sign up, share your data, give us your information so we know how to reach you when these opportunities for research show up, and we can communicate with you via email, and you can also reach out to us. So again, I want to thank you for joining us on behalf of ACP, iConquer MS, and the MS Minority Research Engagement for this next chat with Chat. And at this time, I'd like to introduce Dr. Surachat Noor-Surachez. So, and Chat, I'm turning it over to you.
Thank you so much, Lola. And I'd just like to introduce myself quickly. My name is Surachat Noor-Surachez. I'm a faculty at the Harrison School of Pharmacy at Auburn University, and really happy that to see everyone is here. And my nickname is Chat, so people just call me Chat, and that's why we kind of named this webinar Chat with Chat. So basically, I'm going to be the host. And before I introduce our speaker today, so just like to kind of do the housekeeping stuff. So what we plan to do today, we're going after I introduce the speaker will spend about like 40 or 45 minutes, to present her work. And then we'll kind of like to ask you to hold your question up until she finish her presentation. And also at the same time, you have the chat, as is another chat function. So if you like to kind of type your questions while she is presenting, and then I will collect the questions at the end as well. So you have two choices: either wait until the end and you can ask her question yourself, or you can type your questions that you have during her presentation. Okay. So, and that is what we plan to do. So now let me, it's my pleasure to introduce our speaker today, Dr. Nina Bozinov. And she completed her medical school through the University of Washington, and then she kind of moved to have her in internal medicine internship and neurology residency at Stanford. And then she stayed at the Stanford for other 2 years for her fellowship in multiple sclerosis and also clinical neuroimmunology. And while she's spending time there, she also was selected through the National Multiple Sclerosis Society as one of the senior, and I'm sure that we all know, have heard about this one, Sylvia Lawley fellows that supported additional training in clinical research. So that so then she obtained, of course, she obtained or completed a master's degree at Stanford in epidemiology and also clinical research. After the training, she relocated to Colorado in Idaho and to become the MS specialist at the Kootenai Health. And she provided outpatient care with her MS team, including the 2 clinical nurses and also 2 specialty pharmacists. She continued her interest in patient-reported outcomes measure, which she's going to present with us today, especially in the multiple sclerosis, the measure in multiple sclerosis. And I turn that to you, Dr. Bozinov.
Great. Thank you so much for having me here today. Let me do my screen share. Are you all able to see that by chance?
Lola, you may need to stop sharing.
Oh, I'm sharing. Do you guys see it?
Not yet, in fact.
Okay, let me do it one more time.
I still see the, okay, now Lola, stop sharing. We should see your, yep.
Okay,
You're good
perfect.
now, Dr. Bozinov.
Wonderful. Well, thank you so much for having me today. Really excited. I'm going to try to power through what took me many months of doing research, just so we have enough time at the end to really kind of do some questions and have some good dialogue. The title of the talk is Measuring the Quality of Life of People with MS and Findings from the Real MS Study. This is primarily work that I did during my master's program at Stanford, but have continued to kind of look into additional factors since I've transitioned out of that and into my new role. So my only disclosure is, again, I was a prior National MS Society Fellow. This is just the overview of what we'll talk about today. And then just to remind everybody, as many of you probably already know, iConquer MS was a database developed in 2014. Surveys are administered roughly on an every 6-month basis. At the time when I did this research, there were actually 8 time points available. And then, as many of you know, there's collection of demographic, clinical information, and then quality of life questions. And that's what we're going to highlight today. So this is just the traditional overview when we think about some of the stages of multiple sclerosis. So again, we think about this pre-symptomatic period where maybe there are changes in an MRI. We think about relapsing, remitting, and then at some point in time, potentially transitioning into secondary progressive multiple sclerosis. And then this blue line here just defines what we traditionally think of as primary progressive multiple sclerosis, which is somewhat worsening over time. These subtypes have changed a little bit over as we know more, but we still tend to use them. So for the purposes of this talk, we'll stick with those. There are so many symptoms that can be attributed to MS. That's why, thankfully, I have so much time in my clinic visits to really dive into many of these symptoms as we think about how they impact quality of life for people living with multiple sclerosis. Again, fatigue is one of the major ones we think about, bladder dysfunction, cognitive changes, mood changes, pain. But many of these factors we need to focus on as we think about how we allow and help people live their best life. So what do we think of when we think about quality of life from a research standpoint? So we think about health-related quality of life. When we think about things such as for multiple sclerosis specifically, we think about how factors such as disability status, depression, fatigue, age, and other factors can impact those quality of life measures. And then we, of course, think about things that either are or are not associated with MS, such as depression, anxiety, and other health-related conditions. Patient-reported outcomes or patient-reported outcome measures, so PROs or PROMs, are basically questions we ask the patient and they kind of self-report for their quality of life measures. And again, sometimes these are scales or summary measures or other types of ways that we define how to ask those questions. So why is this such a complicated topic? Partially because there are so many different ways we can measure quality of life. The list is even longer than this today. But again, different clinical trials, different clinical practices use a different combination of surveys. And so they measure quality of life in different ways. So when we think about quality of life and what we know about certain subtypes, so, again, some symptoms such as fatigue and cognitive impairment, walking difficulty, bowel bladder function, they can be more associated with people living with more progressive forms of MS. But we certainly know that they can be very prevalent in people living with relapsing remitting multiple sclerosis. And again, these subtypes are a little bit less critical as we think about quality of life. But again, presentation. So most of people are going to be defined in that relapsing remitting category and less so in the primary progressive. When we think about age of onset, those with primary progressive tend to be a little bit later. The sex ratios are a little bit different. And then we think about where those lesions potentially are, can be different for basically brain versus spinal cord. So what are many of the questions that we continue to have about quality of life? Again, do subtypes make a difference in terms of thinking about the clinical course? There are similarities for things like primary progressive and secondary progressive. Do we lump those together? There's been question over time whether those are kind of can be thought of on the same spectrum. On the flip side, we know that in order to be defined as secondary progressive, people first have to be defined as relapsing remitting. So there are similarities there. And then how do those health-related quality of life measures kind of are impacted by some of these other variables that we think about? And then how is the clinical trajectory and treatment tied to MS subtype? And then how does subtype independently potentially relate to quality of life? And so that's really what the aim of this study was to look at. So when we think about neuroqual, just to give a little bit of background here, we think about, it's defined in 3 different domains: physical health, mental health, and social health. And then each of those get kind of broken up. So for physical health, we think about function. So that's defined as upper and lower extremity function. And then we think about symptoms of physical health, including sleep disturbance and fatigue. For mental health, it's split up into emotional and cognitive health, and emotional having the kind of categories of depression, anxiety, stigma, emotional and behavioral discontrol, and positive affect and well-being. And then cognitive health, including cognitive function and communication. And then social health, including ability to participate and satisfaction with social roles. And so in theory, they kind of cluster into these bigger categories. So one thing that's very tricky from a research standpoint sometimes about the neuroquality of life measures are that for some of our values, higher scores are better. And for some of our kind of values that we're looking at, higher scores are worse. So if we think about fatigue or sleep disturbance, anxiety, depression, stigma here at the bottom, higher scores are considered to have more impairment or be associated with worse quality of life. Whereas things like upper extremity and lower extremity function, in theory, you want a higher score, right? Because that means you have more function in those areas. And then this is just to show that a few things. So one, this is the questionnaire for lower extremity function for the short form. And essentially it includes things like, are you able to push open a heavy door? Are you able to run errands and shop? So again, every survey question has some limitations to it. So on one hand, we're asking additional things, not just lower extremity function, potentially like heavy door opening, and maybe an inability to run errands and shop are due to other things such as fatigue. And so these surveys don't just capture only what they're asking, they do capture some other things as well. And I see a chat and somebody can interrupt me if that's one I have to respond to, but I'll keep talking for now. So not to dive too much into this, but just to understand that basically when those surveys are completed, you get a raw score, and then those raw scores are basically transformed into something called a T-score. And the T-score basically allows you to look at the standard deviation and how much you are away from that T-score, with basically the mean of 50 tells us if we have mild, moderate, or severe symptoms in that category. This is another one that's important. This is patient-determined disease steps. This is supposed to be similar to the EDDS, the EDSS, the Expanded Disability Status Scale, which is the one that is primarily used in clinical trials. This one is different because it's patient-reported. And you can see that primarily this is focused just on walking and lower extremity function. So again, for our study aims, we did a descriptive analysis of participants and then looked at the association between MS subtype and some of the quality of life outcome measures. So although there were a lot of participants in the beginning, when we kind of took out people that didn't have completed surveys and other kind of factors, also removed, there were only 31 participants that listed clinically isolated syndrome as their subtype. And although this is very important to look at, because it was a lower number, it creates problems in terms of the modeling. And so for the purposes of being able to have some rigorous statistical analysis that those people were removed from this analysis. I won't dive into too much detail here, but just to show you that we did generate tables that basically had people divided into their subtype here and the total here, and then looked at the demographics that were filled out, as well as some of the clinical history and how much follow-up time people had. So this is just an example of some of the graphs that were created. So this looks at essentially kind of this, sorry, the text is very small. So this is clinically isolated syndrome, relapsing, remitting, secondary progressive, primary progressive, and it looks at the current age, and this black bar in the middle is the mean. And then you basically see all of the points here. So that's every single response is one of those black dots. This one looks at age of symptom onset, and similar to what we know, those with primary progressive tend to have a later symptom onset or later diagnosis than those with relapsing remitting multiple sclerosis. And again, those with secondary progressive initially had the relapsing remitting, so we expect those to be similar. And then here's years living with symptoms. And again, those with secondary progressive, we would expect that they would be living with symptoms the longest. This is again that disability status score that's filled out by participants. And as we expect to see, those that are living with secondary progressive or primary progressive multiple sclerosis do have higher disability scores. And again, that's mostly just focused on lower extremity function. Any questions before I move on to the next section? See one here. Oh, that was just you, chat. Okay. So again, this one actually, let me spend some time explaining this one a little bit. So these are called violin plots, and they look at quality of life basically by subtype. So let's take a peek at this one here. So here's an example of upper extremity function. This has the number here. And again, to remind you, the higher score indicates better health. And so again, if we look at basically people with relapsing remitting multiple sclerosis, and we look at that red line basically being 50, so that's the mean, we have more of a portion of those participants reporting higher upper extremity function. Whereas when we look at secondary or primary progressive MS, there's more of a distribution, but if we look at where the most of the dots are kind of falling, we see that there's more dots that are reporting kind of lower scores for upper extremity function. But then interestingly, when we look at something like fatigue, it kind of does have a similar shape to it and a similar distribution of those points, kind of saying that many of the people living with MS, regardless of their subtype, are reporting kind of higher levels of fatigue. And then this is another example, again, which is lower extremity function, which kind of not surprisingly and similar to that PDDS score, those that classify themselves as secondary or primary progressive tend to have a worsening lower extremity function scores. This is just another example looking at anxiety, depression, emotional behavioral discontrol, and stigma. And it's interesting because if we look at things like anxiety looks very similar across the distribution, as well as actually depression. And so again, we need to dive deeper into whether these are true differences or they're similar among subtypes. But the nice thing is that being able to visualize some of the data is always helpful in kind of telling a story in itself. And here are the scores again for things like satisfaction with social roles, ability to participate in social roles, positive affect and well-being, and cognitive function. And so we see in many of these, like for example, here in satisfaction with social roles, the distribution of secondary and primary progressive participants looks pretty similar if we look at the shape, compared to where we can see there's really a clear difference in terms of the distribution and the shape, and there's more of that spread in the people that are classify themselves as relapsing remitting multiple sclerosis. So what are our thoughts of just that portion of it? So again, anxiety, depression, and emotional behavioral discontrol, as well as cognitive function and sleep disturbances, tend to be similar across the subtypes. And then things like physical functioning, social health, stigma, positive affect, and well-being tend to be different among those that classify themselves as progressive MS, either secondary progressive or primary progressive, versus relapsing remitting multiple sclerosis. So then we wanted to take a look and think about changes over time. And so how we looked at changes over time is basically that was that kind of smaller group of participants that we talked about, because we needed not just the baseline study and baseline quality of life factors, but we needed people that had completed at least one second time point in terms of when they had filled out additional surveys. And so what we can see here, so these are actually looking at the raw scores, not those T-scores. And this looks at the number of days. And for each of these dots here, there is a corresponding dot at the point at which they filled out their second time point. And again, it's the score at the baseline and then the score at the later time point. And so again, I think the important thing is not to focus on each separate dot, but to focus on the overall trends of what we see and how we see things changing. And for the sake of time here, I didn't include all of the measures, but I included some of them just to get an idea. So for instance here, and we have to remember that the number of clinically isolated people that filled out the survey was only 31. So there's naturally some more variability there. But when we look at upper extremity function, we see here with clinically isolated and relapse and remitting, visually we can see there's a difference between those two groups and where they stay versus where those with secondary or primary progressive multiple sclerosis kind of are in time. So both at baseline and then potentially kind of where they go over time with some slight worsening. And similarly here for lower extremity function. And, one interesting question that came up with some of this analysis was, again, our relapsing remitting participants are kind of seem like they're staying relatively stable over this time period. But then if we look at our secondary progressive people that are participating, they definitely have a lower score to start, and they maintain or get slightly worse over time. But how are people getting from reporting this score here with relapsing remitting to eventually crossing over to report a lower score here? So again, we don't have enough data or time points, but again, how does that trend look? I think that was something that was mentioned that I think is very interesting. When we look at things like, again, anxiety or depression, we can see that actually, regardless of subtype or predefined subtype, scores can be somewhat similar. And even actually with anxiety, it's not fully shown here, but sometimes what we see in clinic is that anxiety actually improves a little bit after diagnosis as people get more kind of used to the diagnosis, maybe understand where things are going. Maybe they get on a treatment and they feel like things are stable and they've had, one of those follow-up MRIs, which did not show any changes. And so sometimes we tend to see some improvement in anxiety over time. So the other thing that's important as we think about what that means from a clinical standpoint is something called minimally detectable change. So even though we see basically a change in a score, what does that change really mean? Is that really a change that equates to something that's meaningful to somebody? And so they actually published, based on NeuroQual, there are kind of scores in terms of where minimal detectable change falls. And so we can see here, this is change over time. So for example, this is our relapsing remitting group, this is our secondary progressive, and this is our primary progressive group. And then this just shows you, again, these numbers are tiny, so sorry about that, but essentially this just shows you what percentage of people in each of these categories stayed the same versus had a better score or a worse score based on minimal detectable change. And so, for example, we can see for the relapsing remitting group that even something like upper extremity function, actually 96% of people really did not meet that threshold for a minimally detectable change based on their baseline reporting of their score and their follow-up reporting of their score. Or even things like, and this is where it gets tricky, people that, for well-being, 58% of people didn't meet that threshold for change, 23% had a better score, and 20% had a worse score. So again, kind of speaks to some of those challenges, even as we think about how we measure quality of life and all the factors that potentially go into quality of life. But overall, those factors that really over 80% showed no change despite whatever subtype was listed included cognitive function, upper extremity function, lower extremity function, stigma, and sleep disturbance. And again, I think this brings back to the question of, and just kind of creates more questions of, maybe the duration of time isn't long enough to measure, and what are the other things we need to be thinking about that are factors that are changing along with some of these changing quality of life outcomes. So this just is kind of further showing what we saw before. So again, this is just what we saw on the last graph, showing how many percentage of people for each of these categories had improvement versus no change versus worsened. And again, actually, there was a trend towards improvement in some of these over time, including fatigue, emotional behavioral discontrol, and anxiety. And I think that kind of goes back to what we were talking about 2 slides ago, which is sometimes you do notice some improvement either with life adjustments or maybe once people get on treatment, or now that people are in, maybe more routine medical care, some of those symptoms are being addressed. And then in the group that classified themselves as secondary progressive MS, sometimes there was a trend towards worsening scores in ability to participate and satisfaction with social roles, positive affect, and well-being, as well as depression. So certainly those are things that need to be looked into more. So the next step we did is basically we made some statistical models. This is not what we're going to go into in detail, but just to show this is what the statistical model looks like as we plug it in for programming. And we looked at actually 13 separate models for the neuro quality of life outcomes. And part of that was based on, there was some kind of analysis before that tried to see, could we really take those outcome measures and cluster them? So you remember in one of those early slides, we had physical health, emotional health, and mental health. And could we basically not make 13 separate models, but potentially collapse those groups into one of the larger groups? But when we looked at both the changes over time, as well as kind of what they were measuring, they did seem to measure different things. And so ultimately it was felt like it was best to just not try to make them the same thing, but to really do the 13 separate models. But in terms of the subtype, we did find that those with the progressive subtype listed, either primary progressive or secondary progressive, were similar enough where we did group those together for the modeling purposes versus the relapsing remitting multiple sclerosis subtype. So some of the things we looked at, so obviously the time between survey responses. So when we think about change, if somebody filled out one at baseline and one, 1 year later, that may be a different change in responses compared to if they were, filled it out 3 years later. Also looked at age, sex, cohabitation status, insurance, employment, highest education, and the disability steps, the patient-determined disease steps. And here, this is just to show that this type of model, one of the nice things about it is it allows each participant to kind of have their own baseline instead of collapsing and saying all participants had to start out from the same starting point. And as we know in MS, it is so unique and everybody is so different. So it really is critical to allow each person's starting point to be different. So this is basically the summary. I took out a lot of slides showing each of the results from the modeling. But essentially what we found is for the disability scores, those that really classified themselves as having moderate or severe disability for the patient-determined disease steps was associated with worse upper and lower extremity function, which as we looked at kind of what those questions are, makes sense in many ways. Fatigue, sleep disturbance, depression, anxiety, stigma, emotional and behavioral discontrol, positive affect and well-being, cognitive function, communication, and ability to participate and satisfaction with social roles. And again, I think this really, in many ways, probably oversimplifies, again, patient-determined disease steps is really just capturing that lower extremity function. But what are all those things that rolls into that? We did look at insurance status, and those that unfortunately were uninsured and those that had Medicaid did have worse fatigue, sleep disturbance, anxiety, depression, positive affect and well-being, cognitive function, communication, and ability to participate and satisfaction with social roles. Living alone was associated with worse positive affect and well-being, and male sex was associated with better participation and satisfaction in social roles. And so when we think about what all of this showed us to start, and again, much of this is, kind of the launching point, many of those quality of life measures actually remained pretty stable over time, and some of them, which we had talked about before, even improved over time. And so, does the neuro quality of life surveys, do they capture the correct experience for a person living with MS? Is the follow-up time we have really long enough to show that change? So if you remember, we looked at basically the lower extremity function of those with relapsing remitting multiple sclerosis. And then we saw at a lower point where those with secondary progressive. But what does that transition look like at some point? Since we know that those that are defined as secondary progressive were initially defined as relapsing remitting. And then again, fatigue, which is considered, potentially to be worse in those with progressive MS, in our group looked pretty similar across our participants and the subtypes. Could some of that be related to when and how we're capturing survey responses? And we weren't able to adjust in this analysis for time living with MS. And as we know, MS really does vary a lot in terms of oftentimes the initial onset versus, how long somebody's living with MS. Both maybe in terms of the disability, but also in terms of adjustment, how people have adapted their lives. Do our results, are those similar to other databases for people living with MS, even after adjusting for things like disability status? Progressive subtypes were associated with some worsening physical function at baseline, but there are so many other factors that we know get associated with non-physical functioning quality of life outcome measures. So how does employment status and potential changes over time, the disability status, things like insurance status, access to healthcare, how are these things playing a role? And how do we better incorporate some of these measures into future research questions? And those were kind of the big highlights I had. I kind of sped through that so we could have some time to do some discussion. Here were some of the references related to the research. And that's mostly what I had. I know there's a list of questions, but I'm also just excited to hear what people have to say. So I'll pause there.
Mm-hmm. Thank you so much, Dr. Bozinov. I kind of like to give the privilege to people who are actually live with us right now. And in fact, and again, I will allow everyone, to speak up for themselves if they are comfortable to. Otherwise, I have a list of questions here. But there's one question that somebody here wrote in the chat box there, asking about, in fact, it's a very good question to me because I think if I am correct, you haven't mentioned about if you actually take the medication that patient were using into account, if and see if indeed, that those medication actually have an impact on the quality of life. Can you address that issue?
Yeah, so outstanding question, which I can address a little bit as both kind of somebody that did the research, but also as a clinician. So it's really tricky from an analysis standpoint to think about how we incorporate that, especially because, as we know, sometimes those medications change over time. And so from my standpoint, it was difficult to fully figure out how to incorporate, there's so many of those medications. So do we look at individual medications, but then what if somebody makes a change or there's a gap in the treatment? But also, do you classify those that are traditionally thought of as high efficacy or lower efficacy, and at what time point? So what we know now more so is that as we have more options for treatment, those people that are newly diagnosed often get started on kind of those more moderate or highly effective therapies, whereas, in the past, we didn't always have those options for treatment. And I know many people were on the interferons and some people still are. So I could not include it in this analysis. I think it's a great question, and certainly potentially plays a big role. Also things like, relapse status, how many people were feeling like they had a relapse over time. So, and any of the other accelerated for a cure, I Conquer MS, kind of members are welcome to jump in if they have other thoughts, but it's a great question and I could not include it.
Mm-hmm. All right, so I just like to give opportunity to the audiences here to ask Dr. Bozinov questions that you have. Anyone have any question? You can actually unmute yourself first, and then you can ask the speaker the questions. If nobody take opportunity, I'm gonna grab it. So, all right. So actually, this is not my question, but it's a question that we ask people who are interested in this webinar, to kind of submit the questions as well. One of the question is I would like to bring here is what I think you probably touched on this a little bit, but which one is the most surprising result to you, or the result that unexpected most to you?
Yeah. I mean, I think from, they'll take it in two approaches. I think one, just as a learning experience, working with this kind of data, there were a lot of surprises. So again, even things like, people having different time points or in a different amount of completed surveys. We know, as survey participants, we don't complete every survey at every time point. So how to really think about that in terms of really then coming up with a solid ability to do research on that. Certainly that was a great learning experience for me. From an actual response standpoint, I think that in some ways, kind of honing in on the potential differences as we think about subtype versus kind of the non-differences. So for instance, things like, fatigue, which I pretty much talk about all day, every day in clinic, that it really was very prevalent, or things like there was some trend towards some improvement in anxiety and depression over time. I think there's some real optimism and hope in that as well. So I think that was just kind of interesting, seeing it both from the clinical and the research side.
Mm-hmm. Mm-hmm. And again, I kind of like to give more opportunity for everyone who are here to ask our speaker your questions. So any questions?
Yeah, I'd just like to ask, it looks to me when you presented the data, like people are pretty stable over time. I'm not sure how long, but I think it's like 2 years, is that right?
Mm-hmm.
And that the kind of takeaway was that if you have primary progressive versus secondary progressive, your timeline and your quality of life does actually remain pretty stable. Do you think that's a
Yeah,
correct
and
assumption?
I think that they're potentially. So I think a lot of things. So one question is, when are we capturing people during their time living with MS? So are we capturing some of those people at a more stable period of time? And that's hard because we don't really have a lot of questions to say like, hey, do you feel like you've been stable between, this survey time point and the last survey time point? Do you feel like things are worsening? That would be something potentially interesting. Certainly when I'm in clinic talking to people with either progressive forms of multiple sclerosis, we think about things changing on a year-to-year basis, more so than things really changing faster. And sometimes when I'm seeing people that have been living with MS for a long period of time, and they feel like they're walking or something is worsening quickly, I think, we have to check for, disc bulges, other herniated discs, other things than MS, because we don't expect MS to worsen that quickly. So in some ways, I think that replicates what we think about naturally with progressive types. But the other thing is, and I saw Robert on the video at some point, is, how do people get from that lower extremity function where they actually score pretty high to where they get to that one where they score lower for secondary progressive? Where do we make that change? What does that look like? And I think that's a really interesting piece that we're not picking up right now.
Any other questions? That's a very good question, Pete, by the way. Yep. Any other questions? Otherwise, I'm going to grab it. And since Dr. Bozinov also mentioned Robert, I think, I like to bring this question up. Maybe Robert also can jump in as well. So the question from, again, people who register for this webinar is, how can we get the quality of life endpoints to be used in the clinical trials? And because, this is an important outcomes to the patients, and then the follow-up question would be the same person also asked, why doesn't the FDA require or at least encourage the pharma companies to show the quality of life improvement before they approve the new treatments?
Yeah, so I'm actually going to take it one step further than that question and add on to that question, and then maybe Robert will want to jump in. But I think that not only how do we get quality of life factors to be incorporated into clinical trials and things like the FDA, but how do we actually incorporate it into clinical care in the routine clinic setting? So, one big lesson I took away from this, again, I came over and, moved to a new location where there wasn't an MS provider, was an opportunity to kind of start some things from scratch. And so we actually ask a lot of patient-reported outcome measures at each of the initial clinic visits and then get them annually. Because again, I think it's very important to track more than just MRI changes and the neurologic exam, and really to focus on that quality of life and how things are changing over time, because it gives us information and at least starts a conversation as well. I will also say that, the newer clinical trials are requiring to incorporate some patient-reported outcome measures and quality of life outcome measures, but it's hard because, as you saw before in that initial slide, there's so many of them, so there's not really a uniform set that everybody is using. There's some trend towards, ones or others, but yeah, and I don't know if Robert wants to say anything, or anybody else really with some knowledge about some of those patient-reported outcome measures.
I'd be happy to. I'm sorry, I froze just as Chat was asking. Chat was asking the question, so I'm going to imagine what the question was, and I make the following comment. The design of clinical trials in the past has largely been done by clinicians, and the outcome measures that have been included historically in a sort of legacy clinical trials have been the outcome measures that clinicians are familiar with and resonate with, like relapse frequency or the expanded disability status scale for disability, which is a very gross measure. I'm sure, as Nina probably mentioned, I apologize, I wasn't able to come at the beginning of this. And so it's partly due to the fact that while every clinician asks a question of the person with MS that's in front of them, how have you been? Or some question like this, how have you been since the last time I saw you? And that is actually collecting patient-reported outcomes, but there's no formality to that. There's no, you know, and while patient-reported outcomes as, you know, research tools have been around for who knows how long, 20, 30 years, they don't appear in the clinical practice, and therefore not in clinical trials. The world is changing. As an Australian surfer, I could say there's a wave coming. How do I catch that wave? How do I position myself to catch that wave? And the clinicians, the wave is actually being driven now by people affected by MS and people in other with other health conditions in conjunction with the FDA. And so there are attempts right now, not attempts, successful attempts to get various symptom, ability, and quality of life patient-reported outcomes qualified by the FDA to include in clinical trials. And once that happens on a routine basis, those results, if positive, will appear in the label of the drugs. So in addition to saying the drug can reduce relapse rates or change EDSS over a period of time, or slow the progression of EDSS over a period of time, they will ultimately talk in the labeling information about fatigue or about sleep disturbance or who knows what. It's a marathon, not a sprint. It's being driven at the moment by an initiative of the FDA's called Patient-Focused Drug Development, which ICONC-MS has been very fortunate to participate in a number of ways. We've had specific collaborations with pharmaceutical companies that I know at least one or two people on this call know about. And also we actually participate in the PRO consortium of the Critical Path Institute, which is a public-private partnership that works with the FDA to get things qualified. So I was asked this question late last week, earlier this week, I can't remember, in a workshop, and the answer is, you know, you can, as a clinician, it's a good idea to keep abreast of the field. Maybe you don't want to do anything right now, but, you know, participate in grand rounds related to PROs, be a little bit more attentive to the literature in PROs, and maybe even try, like Nina is doing, probably more than just try, but if you're a clinician, incorporate a simple PRO measure into your routine evaluation. And, you know, even if it requires you to type things into the notes, get that information into the electronic health record so you can compare or monitor a treatment effect. So there's a lot going on, and I think it's a very exciting area. And I'd like to think I had an opportunity to hang 10 on that wave at some point.
All right.
That's a surfing reference.
Thank you so much, Robert. I don't mean to put you on the hot seat, but I just like to address that, Elaine. I hope that you asked similar question to the first question that I asked to Dr. Bozinov. I kind of like to move to the next question. We still have like a little bit, like 5 minutes, so we have quite a few questions now indeed. So the question is, so do you actually have people who have MS for 50 years in your sample? And if so, what percentage?
I don't know that. I'm trying to think if I have something that really represents that. Let's see here. So I do have some graphs that basically kind of show the full distribution, but not in front of me and not that I fully remember. I think that the max number of years is probably, yeah, there's a few people, there's maybe 7 people that have years reporting years since symptom onset to be about 50. And it looks like, yeah, those are all people more or less in that secondary progressive MS category.
Okay. Yep. All right.
But I
So,
always think, sorry, last follow-up is, I always think age is so important. And the problem is, older people living with MS oftentimes aren't included in those clinical trials, and so as we think about the effects of medication and goals of all of these things, my always question is, did you look at the different age population? So I like that question.
I think we can have time for one more question, and then I'm going to close our webinar. So somebody actually curious about as a sleep or health professional herself or himself. So how much of those survey reported sleep problems, and whether these were linked directly to MS or were simply unrelated comorbidities?
Yeah, so really great question. And I don't remember if there are questions related to things like, have you been diagnosed with obstructive sleep apnea? Do you have, some of those other factors that may suggest whether there are unrelated comorbidities. I do love sleep. So I really, I talk about sleep a lot in my clinic because, again, if you're not sleeping well, you're not going to have a good pain tolerance. You're going to be more fatigued. Your cognition's going to be worse. Sleep is so critical for all of us. And there can be so many factors that can contribute to sleep. So I always try to ask, pain, is it pain? Is it the bladder? What is keeping you from sleeping? Sometimes it's really just, things like central sleep apnea, which I think is probably vastly underdiagnosed with in people with MS. So I send a lot of people for sleep studies. And I don't know how much some of the real MS stuff is diving into some of those sleep things, but I think is a fascinating area to dive into more. So.
All right, thank you so much for your response to that question. And it kind of, as I said, we have a couple more minutes, and I know that Dr. Bozinov going to have another meeting right after this as well. So I would really like to take this opportunity to thank Dr. Bozinov for her presentation and also her time that she have done the project and also presented this project that she have done with the I Concur MS and share with the community. So thank you so much. And I'd like to thank everyone for being here today. And another thing that I just like to make announcement that we will do this type of the webinar one more before the end of the year. That's our goal. So please stay tuned about who's going to be our next speaker. And once we kind of be able to finalize that name and confirm everything, we'll let you know as soon as possible. And one more thing that I kind of like to read it out loud because, when Robert talking about wave and stuff, Sarah actually typed it in the chat and she said that, and as members of the I Concur MS, we all are, or you are part of the wave. And I just like to use that statement to conclude our webinar today. Again, thank you so much for being here, and I'll hope to see you soon. And you guys have a good day. Bye.